So let's talk about that for a moment. So we were just obviously referring to new therapies that are in early phase 1-2 studies for these non-covalent BTK inhibitors. But let's talk about what we're doing in practice now. So a patient who has received ibrutinib and is progressing, then what is common practice that you do now?
So I think it's important to recognize that we're still following the IWCLL guidelines. And what that means is, yes, if someone does develop progression of disease, you can justify discontinuing the therapy and deferring additional therapy until the patient has an IWCLL indication.
So true indications of needing therapy. Farouk was suggesting that.
Yes.
Hitting that home point. Go ahead.
But in my own practice, when we are talking about a relapsed patient or a patient progressing on ibrutinib, I do find the need to wait, potentially like losing some of the advantages we have of getting patients into deep remissions. So if my second choice or my next line agent is going to be venetoclax, and venetoclax's greatest risk factor for an adverse event is going to be tumor lysis syndrome, I could really obviate that issue by initiating therapy earlier before the patient really is at high risk. So, it's important to weigh. I mean, we don't know if we're sacrificing any therapeutic benefit in terms of progression-free survival by earlier initiation, but there are things that, obviously seeing the rate of change and seeing what we might be expecting that would allow us to hopefully obviate some of the adverse events. I would like to emphasize that a lot of the data regarding these very abrupt and aggressive progressions after ibrutinib were really in chemoimmunotherapy-treated patients.
Yep, absolutely correct. Very different now.
And I think it's very important for people to see that. And when we look at these patients who've never gotten chemotherapy, even if you were to compare 17p deleted patients on ibrutinib post-chemoimmunotherapy versus 17p deleted patients
progressing on ibrutinib, frontline.
Right, but I'm just talking about comparing 17p to 17p deleted patients with the only difference being chemotherapy. We see the non-chemotherapy treated patients just doing so much better. So it's definitely, I don't want physicians to panic. I don't want patients to panic. I think that, progressing on ibrutinib is something that need not necessarily be concerning for having immediate therapy in place.
However, I think it's a good point that you make, that right now there are very, very few patients who progress on ibrutinib frontline, as you just pointed out, and we can argue that the high-risk patients. So most of the patients that are out there, they still really come from the chemoimmunotherapy area. They may receive FCR years ago, even BR more recently, and those patients still, I think, we are discussing about progression, but sometimes the progression are not necessarily the same depending on the patient. Some patients, as you have pointed out, can progress with this, increasing lymphocytosis. Will be very nice, and I do all the time, to really add venetoclax. With other patients may have a different type of progression, they different type in terms of more lymph node-based progression, and those patients, well, you may need to really look for a Richter transformation and do something else. So I think we need to recognize that sometimes the progression are not the same, and at the same time, as we were discussing before, maybe the allele frequency is low, maybe in the peripheral blood, maybe different we know in the bone marrow, but we know that still the drug is working. It's working because it's a part of the population who really comprise the CLL. So it's completely understandable that sometimes the flare, that not may necessarily really bad, but it may happen because you still are really blocking a percentage of CLL cells. They are maybe in the lymph node. So I think, again, I agree that we shouldn't really make people panic, but I think we need to be aware. And the another thing is that it's very easy to really see that, right? As soon as the patient stops, a couple of days, you may see right away if this phenomenon is going to happen or not, and act accordingly.